So let's look at our epidemiology, and we're looking at the distribution of this problem of maternal mortality. How is it distributed? Which groups are affected? Okay, so we are looking at the distribution and pattern of this problem. So 95% of all maternal deaths occur in lower and middle income countries. And that is basically, when we mention lower and middle income, we are referring to sub-Saharan Africa and then the South Asia. Okay, the Afghanistan, we are referring to India. Those are the countries that are in the South Asia. So this reflects inequalities in access to quality healthcare services and highlights the gap between the rich and the poor. So this is a problem of mainly low and middle income countries. You find other developed countries, they have their maternal mortality ratio. You can check the maternal mortality ratio of USA, okay, and find out how of Germany, okay? Then you compare with us who are celebrating a 189 per 100,000. Then you will know that indeed this is a problem of sub-Saharan Africa and South Asia. So according to a study that was done in 2020, the Fragile States Index, 9 countries were very high alert countries, and these are the countries that we call high alert countries, meaning that their maternal mortality ratio was very high. And you can see these are the countries which are were war-torn. You can see, for example, you can see Yemen, Somalia, South Sudan, Syria, DRC, Central African Republic, all these countries. They are in sub-Saharan Africa, and those and the others are in East Asia. And you see most of them when you check, you can see South Sudan, you can see Somalia, you can see Central African Republic, DRC, all these have been disrupted by wars. So these ones also have an impact in as far as dealing with maternal mortality ratio statistics. So women in low income countries have a high lifetime risk of maternal death, which is 1 in 49 compared to 1 in 5,300 in high income countries. So the lifetime risk of a mother dying, her lifetime risk of her dying is 1 in 49. That is in low income countries. But her risk of dying in high income countries, it is as low as 1 case in 5,300. So you can see how high this is. You can see that a mother has a lifetime risk of 1 in every 49 he has a chance, okay, a risk of 1 in 49. And then her risk is 1 in 5,300. So you can see the risk is really so low in high income countries. So in other words, maternal mortality ratio or maternal mortality and morbidity is a problem of low and middle income countries. So they usually ask the causes of maternal death, and this is usually you need to check the statistics. You're going to check the UDHS report, but of course, to know the exact percentages, how much did severe hemorrhage contribute? How much did the hypertensive disorders contribute? And how much was contributed by sepsis and safe abortion and complications during delivery? These are the 5 major causes of maternal mortality or maternal death in Uganda. Most of the causes is severe hemorrhage, excessive bleeding or severe bleeding. And mainly it is the PPH. It's the leading cause of maternal mortality is postpartum hemorrhage. So I hope you know how to define postpartum hemorrhage. Postpartum is bleeding from the genital tract of the mother of more than 500 mils if it is a vaginal delivery, and more than 1 liter or 1,000 mils if it is a C-section. If she was operated, if she gave birth by C-section, cesarean section, and she bleeds more than 1,000 mils, or if she gave birth by vaginal delivery and she bleeds more than 500 mils, or any blood loss that can disrupt her hemodynamic stability. For example, she was already anemic and she bleeds 200 mils, then she qualifies to be called a PPH. Are we together?
Yes, doctor.
Yeah, so any blood loss that can disrupt her hemodynamic stability. She gets features. She can bleed little and she's in shock. She bleeds little. She has rapid weak pulse. Okay? All those symptoms of hemodynamic instability. If they come in, then we call it a PPH. APH, we are looking at bleeding before
Deli-
delivery, and after how many weeks? Because not every bleeding before is regarded APH. After how many weeks?
After 28 weeks.
Yes, after 28 weeks. Then before, what is it called? Before 28? If she bleeds before 28 weeks, what does that become?
It is an abortion.
An abortion, okay? Yeah, so you have to know that this is abortion up to this age, and beyond this, it is APH. And now know what are the main causes of APH, which is, and what are the main causes of APH?
Placenta previa.
And previa, and then versa previa. Okay, then you have hypertensive disorders. What are those? You need to know the hypertension.
Preeclampsia.
We have preeclampsia. We have eclampsia. We have
Chronic hypertension.
chronic hypertension. We have pregnancy-induced hypertension. Okay, then we have sepsis. Then we have sepsis, which is the infection of the genital tract, which is more common in the postpartum. It's usually in the postpartum period when she gets sepsis following an infection of the genital tract within puerperium, following delivery up to 42 days postpartum. Then we have unsafe abortion, is another cause of maternal death. Unsafe abortion, we are referring to abortion done in by unqualified or unskilled personnel, and also in unauthorized places. Okay, so even if someone is authorized, for example, even if you're an obstetrician or a gynecologist, but you're doing the abortion in an unsafe place or unauthorized place, then it also becomes unsafe. So the place must be equipped to handle the complications. For example, if you're doing it in a place that does it and you cause perforation of the uterus, you cause hemoperitoneum, and there are no facilities, then it also qualifies to be unsafe abortion, even if it was being done by a specialist. So, unsafe abortion, and then complications that occur during delivery. So those are the main causes of maternal death. You need to know them. Severe hemorrhage, hypertensive disorders, you can even mention them, then sepsis, unsafe abortion, and complication during delivery. So, under safe motherhood, the role of safe motherhood, like the other members had not come in told us, the goal of safe motherhood is to reduce maternal and newborn morbidity and mortality, and to improve the maternal and neonatal health outcomes through prevention, promotive activities to address avoidable causes of death during pregnancy, childbirth, and the postpartum period. So the components of safe motherhood, we have basically what they're usually interested in are the pillars, but we need to know the components of safe motherhood. What should be done to ensure that we reduce the maternal morbidity and newborn morbidity or mortality, and also to improve the outcomes of pregnancy and the delivery of the mother and her newborn baby. So all those the protocols that are done to ensure that a mother gets the best out of pregnancy, labor, and postpartum. It is what called safe motherhood. And it includes the following protocols or components. We have safe pregnancy, we have safe delivery, and safe birth of the newborn. Those are the three components that make up safe motherhood. Okay, and how to achieve these, how to achieve a safe pregnancy, how to achieve a safe delivery, how to achieve a safe birth of the newborn. It should be achieved through pillars. Pillars are like supports. So there are some support that ensure that mother should get safe motherhood. Ensuring that we get safe motherhood, they are something that we must embrace, the pillars, the supports. If it's a house, the pillars are like those supports on either on at different sides of the house. Those are the pillars. And the pillars enable us to achieve safe motherhood, which is defined by these three things: a safe pregnancy, a safe delivery, and a safe birth of the newborn. So these are the 6 pillars of safe motherhood, which include family planning, antenatal, obstetric care. This is delivery, labor and delivery. Then you have postnatal care, that's care after birth. Then post-abortion care. If a mother gets an abortion, how does she get assisted? What are the components of post-abortion care? Components. Yeah. Then we also have HIV or STD control. Then that's how we shall address the EMTCT. I think my colleague covered this. Dr. Main covered it, the EMTCT. When he was covering it,
Not yet.
right? He did?
No.
He didn't cover EMTCT, elimination of mother-to-child transmission. The 4 prongs of EMTCT, those ones you must know. The 4 prongs. You know them?
No, we don't know.
Okay, the 4 prongs. These are like the things that we can do to ensure that we eliminate mother-to-child transmission at different levels. Like you see in the first prong, they're in order. Is primary prevention of HIV among people of reproductive age, both men and women. We are trying to ensure that a mother, a father, any person of reproductive age does not get HIV. It is one way how to prevent mother-to-child transmission. If people don't have the disease, then the chances of having a baby infected at least are not there. So that's what it calls the elimination of mother-to-child transmission. First is by primary prevention, ensuring that the mother of reproductive age, the father or a potential father and the mother are HIV negatives. That's primary prevention of HIV among adolescents, men and women of reproductive age is intending to make sure that people don't contract the disease. If you do primary prevention, condom use, educate on safe sexual practices, and all that, that's primary prevention of HIV among this population. Now, let's assume that we didn't succeed at one moment, we didn't do the primary prevention and the mother has contracted. Now, we are ensuring that we minimize or prevent unintended pregnancies, because if the pregnancies are not intended, then perhaps a mother will not prepare well in terms of ensuring that at the time of conceiving, she has suppressed viral load. Okay? At the time of conceiving, you get, she has no opportunistic infections. Otherwise, if she has, you wouldn't expect her to conceive when she still has an ongoing infection, an opportunistic infection, which usually comes when the viral load is high, okay, or the viral load is unsuppressed. So that means you also do, you prevent unintended pregnancy, so that even those ones who got the disease already, they don't get pregnancies they have not planned, because if they have gotten pregnancies that are not planned, there is a higher risk of her transmitting to her unborn baby. That is prong number 2. You see that we begin with primary prevention. They don't get. After they have gotten, we have to ensure that they don't conceive any pregnancies that is not planned. Because at that time, if it's not planned, probably they will not have adherence counseling. They have not had adherence counseling, so they are not even adhering. They have infections that are not treated, opportunistic infections, which are more common when they when they are not suppressing. The viral load is high. Then prong number 3 are things we do to ensure that if this mother was HIV positive, we didn't achieve primary prevention. Still, even second prevention, we did not prevent pregnancy. She went ahead and conceived. But then how do we prevent the mother who has conceived and is HIV positive from transmitting the HIV virus, her unborn baby? Okay. Now that she has conceived, we tried to prevent her from getting HIV. We didn't succeed. She went ahead and contracted. But after contracting, we tried also to prevent her from conceiving because it was not planned. She went ahead and conceived. But that's not enough. After conceiving, what do we do to ensure that if this mother has gone ahead and conceived, she should not transmit her virus to her unborn baby? What do we do? Now, there are strategies we do here to prevent a mother from transmitting. Adherence. We counsel on adherence. We ensure she is taking her drugs very well. She's on cotrimoxazole prophylaxis for prevention of opportunistic infections. You get. We treat we treat all the emerging illnesses. She's on prophylaxis. All the interventions here we do when she's pregnant and even during the delivery, ensuring that if she's pregnant, she delivers from a hospital, okay, by trained or skilled health personnel. If the child is born, the baby is given a virapin syrup. We discuss about exclusive breastfeeding, okay. The thing we do here to ensure that the mother who is already positive does not transmit her virus to her unborn baby, okay. Do external cephalic version when she's pregnant, baby has a breech. If there is any other indication, maybe you can discuss about C-section delivery, because most of the transmission happens during labor and delivery. So all the things that we talk about, exclusive breastfeeding, because the gut is very fragile and prone to ulceration if we switch the diet, like she was taking breast milk, and all of a sudden we say now we bring cow's milk, so the gut is at risk of ulceration, and you end up causing the transmission of the virus. So all the things that we are doing here, ensuring the baby, if it's a high risk, the baby is going to be on a virapin syrup for as many as 12 weeks instead of 6 weeks. Doing taking off a dried blood sample for PCR, doing all these interventions that are aimed at ensuring that this baby does not contract. That is prong number 3. And then finally, prong number 4, we are looking at support, care, and treatment of these mothers, their families, and relatives to ensure that they feel supported. If they feel supported, they will actually adhere to treatment. Okay? So those are the 4 prongs in elimination of mother-to-child transmission. Primary prevention of HIV, which is prevention of HIV among adolescents, males and females of productive age. That's prong number 1. Prong number 2 is prevention of unintended pregnancies. These days they want to use the word unwanted. It is unintended pregnancies in women in HIV, in people living with HIV, women living with HIV. And then prong number 3 is prevention of mother-child transmission. Okay, the mother is already positive and is pregnant. How do you prevent her from contracting? So they also need to know what is contained in each prong. And then prong number 4 is care, support, and treatment of people living with HIV, their partners, their children, and relatives. Okay. Yeah, so those are the 4 prongs. So these are the 4 pillars of safe motherhood. These are the 6 pillars: family planning, antenatal care, obstetric care, postnatal. The slides are very clear. You're going to go through them and read. We're going to go through now marathon. So this is what family planning involves. We have education, comprehensive medical and social activities, enable individuals, including the minors, to determine freely the number of children, the spacing among these children, and by the means by which this can be achieved. And these are the components of family planning. We have birth control. The birth control is what most people address, but it is not just that. It is beyond birth control, the birth control methods. Okay. Then we have sex education. They educate about safe health practices. Prevention and management of STIs, sexually transmitted infections, preconception care, infertility management. All these are components of family planning. So the family planning is one of the pillars, but also has components. What makes up family planning are these ones. Antenatal, it's a planned program of, it's a second pillar or another pillar. To remember this, look at it this way, that initially the mother has not conceived. So what can we do for a mother to ensure that she is going to have the best outcome for her and the baby? Okay. That it means you can do something before she gets pregnant, prevent the pregnancy. Because if, for example, the pregnancies are next to each other, every year she's giving birth, mean the risk is higher of getting a complication. Probably she has anemia, it had not even healed, meaning the risk of PPH is likely to be high. Probably she got a C-section, now she's getting another C-section, short pregnancy interval. Maybe in the process she got a C-section, now this time around she attempts to push before the 2 years, from the time she gave birth up to the time she conceived, what you call the pregnancy interval. It is from the time she gave birth up to the date she conceived. Those are the 2 years. Minimum is supposed to be 2 years. So you find that she has conceived before the 2 years have elapsed. And she gave birth by C-section. Now this time around, she thinks she has been told that if she doesn't push, she's not a mother enough. So she attempts to push and then ends up with a ruptured uterus. And now she can actually get a problem. So you see, you're doing a part by doing health education. We come to antenatal. After she has conceived, what can we do? It's a plan. Antenatal care is defined as a program of medical management for pregnant women directed towards making pregnancy and labor a safe and satisfying. And these days they recommend, we call them contacts, not visits. So we have a minimum of 8 contacts. The first contact should be done as early as possible in the first trimester, preferably after 2 missed periods. That is before 12 weeks, but after 2 missed periods, meaning that 2 missed periods that we are referring at around 8 weeks or less. 2 missed periods, that means it's about 8 weeks of amenorrhea. Okay, then she can come between that period, but less than 12 weeks. That is for the first visit. The second visit is happening in the second trimester between 13 and 20 weeks. Okay, then the third visit can happen between 21, still in the second trimester, and 28 weeks. And then at the fourth visit at 30 weeks, the fifth visit at 34, sixth visit at 36, the seventh visit at 38, and then finally the eighth visit at 40 weeks. But there are things that are done at each visit she comes. So we call it focused antenatal care, ensures adequate care of pregnant women from diagnosis of pregnancy to time of the delivery. Knowing that what is done in first trimester at the booking visit, where you have to screen for all the infections, HIV, the torches, syphilis, hepatitis B, blood group, take her weight, assess if she has a risk pregnancy, maybe she has a previous risk of preeclampsia. Okay. Discuss the delivery plan, all those things. Does she have any medical illness? This is where you do all the assessments. That is the first visit. And then where they have to give any medication, give it. If she has a UTI, treat it. Do first the first trimester ultrasound scan, okay, for confirmation of pregnancy, because she may be carrying we want it as early as possible to ensure that we know it is pregnancy, because the HCG alone cannot be positive for only pregnancy. What if it's an embryonic pregnancy? What if it is an ectopic? So all this is important in the first trimester. So that if it's an ectopic, we know this is a pregnancy outside the uterus.
Yes.
Okay. So all these things are done for a reason. Then you do a scan around 18, 22 weeks. And that is basically for fetal anatomy, 18, 22 weeks. So all those things we're going to look, find them in these slides. So during focused antenatal, what are the services provided? They are here. These are the services that we provide. Folic acid as early as 3 months before conception. But since most of the times it's not planned, they usually end up getting what? After conception, but as early as possible before 12 weeks, preferably even before 8 weeks. Immunization against tetanus, syphilis, all these things. IPT from 13 weeks, intermittent preventive treatment or presumptive treatment for malaria from 13 weeks up to 36 weeks. Give monthly Fansida. You give Fansida 3 tablets every month from 13 weeks. If she's HIV positive, start at ARVs, that is EMTCT. You discuss adherence. She's supposed to adhere to drugs. This one I'm going to correct. She's supposed to be start at 13 weeks. I'm going to edit that. You do deworming, that is in second trimester, not first. So, but all these things are services that we include under antenatal. Examine the mother to evaluate her pregnancy, any information and education. Discuss with her about the warning signs or danger signs. Okay, discuss HIV/AIDS, infant feeding, as well as then discuss hygiene, responsible fatherhood, male partner involvement, and all that. Screen for risk factors for preeclampsia, diabetes. Okay. Okay. Under obstetric care is another principle. Here, another pillar, sorry. The obstetric care ensures that all deliveries are done by skilled birth attendant or medical professionals. Birth attendants should have knowledge, skills, and equipment to perform a clean and safe delivery. And these are the components: labor and delivery care, care of the newborn, immediate puerperium care, that is in the first 24 hours, and then emergency obstetric care, where there is need for what we call the EMOC, emergency obstetric care facilities, where there is need to do C-section, she has obstructed labor and all that. So these are all components of obstetric care. Knowing that she's able to deliver, should be a labor and delivery care, care of the newborn. What are the routine care of the newborn? If a child is born is okay, what are the components? Immunization, breastfeeding in the first 1 hour, provide warmth, cover the baby, name it, tetracycline eye ointment, care of the cord. All these are things that are done in the first 24 hours. The care of the newborn. Labor and delivery, ensure clean and safe delivery of the mother and the baby, and these are the services offered. Monitoring labor using a pathograph, identification and management of abnormal events, involvement of the partner and other relatives as the mother wishes, ensure comfort of the mother, giving relevant ARVs or ART according to the MTCT guidelines, adequate nutrition and rehydration. What is the recommended, what is the recommended ART in pregnancy? What's the regimen we give in pregnancy?
TDF, 3TC, and DTG.
Yeah, TLOD, okay. Yeah, tenofovir, amivudine, and dolutegravir. Okay, so newborn care, this is the care that is given to the baby immediately after birth, up to the first 24 hours of life. Ensure the well-being of the baby. Give information on newborn care to the mother and family members. The prime the para one. I won't call it prime gravid. Okay, para one. So this includes clearing the airway and ensuring normal breathing, proper cord ligation, and hemostasis. Weigh and keep the baby warm and dry. Examine the baby for any anomalies. Initiate breastfeeding the first 30 minutes, except when the mother chooses not to breastfeed. Immunize the baby before she leaves the hospital with the BCG and OPV0. EMTCT, give appropriate ARVs to the baby in a nevirapine syrup. That is before the baby leaves the hospital, as soon as possible. Immediate puerperium care, that is the first 24 hours after birth, and this is what is involved. You monitor the general maternal condition. Bladder is empty, ensure its bladder is empty. Otherwise, if it's not empty, then the risk of the uterus contracting, it may not contract very well, which may cause which may cause PPH. Ensuring the bladder is well contracted and there is no excessive bleeding. So you monitor bleeding is one of the vitals. What do they usually call the fourth stage of labor? The first 24 hours, we call it the fourth stage of labor, because this is where you're monitoring the bleeding, you're monitoring the vitals immediately after birth. Here you monitor the vitals, the BP, the pulse, temperature of the mother. You offer relief of if she has pain, keep the mother warm and comfortable. You give vitamin A, 200,000 international units. Inform the mother about the changes during puerperium, when to resume the sexual activity within 6 weeks, puerperium, and then nutrition. You discuss the danger signs like postpartum preeclampsia. Emergency obstetric care, we are defining the elements of obstetric care needed for the management of normal and complicated pregnancy, delivery, and postpartum period. This includes managing obstetric complications that might endanger the mother or the baby, reduce impact of obstetric complication on the life of the mother and the child, improve survival and quality of life for the mother and the child who have had an obstetric complication. Postnatal, this is what is involved: care for the mother and the baby after birth up to 6 weeks. And this is what the objectives are: maintain physical and psychological well-being of the mother and the baby, detect or screen for complications for both the mother and the baby, and you manage. If not, you can refer appropriately, provide health education and information on feeding, family planning, hygiene, sexual intercourse, promote couple dialogue, and responsible fatherhood. So these are the services that are given, and the visit schedule. This one you're going to read. And this is how they do the postpartum, the postpartum reviews. Visit is scheduled within 24 hours. That is why they usually are discharged within 24 hours, at least to have done the review postpartum, and then within 7 days, within 1 week of delivery, and then within 6 weeks after delivery. However, it can be adjusted according to the needs of the mother. But as the mother comes in, you have to measure the baby, and usually schedule the visits so that they are matching with the time she's bringing back the baby for immunization. So you need to know the immunization schedule. And now it's updated with malaria vaccine. So you need to know when malaria is given, the malaria vaccine, from 6 weeks up to 6 years. The post-abortion care, healthcare provided to a woman or a couple after an abortion, and these are the objectives. And most importantly, you're going to look at the components or elements of post-abortion care. Okay, these ones you must know them. What are the components? I'm not going to go through them because they are very clear and straightforward. But a mother gets an abortion, she's supposed to receive immediate management of the complication. If she comes in bleeding, maybe they are retained products of conception, she should be worked upon. Okay. If it is she's anemic, she gets blood transfusion or she receives steroids. That is the immediate management. But also need to support her. Okay. You need to counsel her with what she has, because the abortion alone is a devastating situation. So you need to counsel her, link her to other reproductive and health support services. If she's HIV positive, link her to the art services. Okay. Yeah. So these are the components. You need to provide contraceptive and